Okay, looks like we're at about 75, so I think we have a quorum. I'm going to do a quick poll here to see who our audience is. So which of the following describes you best? And I'm going to launch the poll now. If you can click your appropriate category, I'm seeing the numbers go. And Raj, you wanted to know who was attending, so you got primary care docs, specialty docs, APPs, few residents, nurses, students. And it seems to have stopped there. So you get the picture. And those are the results to share. And with that, I'm going to ask Dr. Walsh to start with his COVID update.
All right, good morning. I'm going to talk about two topics very briefly this morning. One is the issue of antibody testing, and the second is new and upcoming treatment trials at RGH for coronavirus infection. So this is a slide some of you probably have seen. This is from Emil Leshow. This shows an outbreak of COVID on 7800, and just to make some sense of this, the numbers, the red numbers, refer to the cases as they occurred in sequence. These are residents in these rooms on 7800, 1 through 11, and you can see how the spread was from room to room. And it's interesting that it is predominantly on one side of the floor, which probably reflects the fact that nosocomial viral infections, and COVID would be one of those, tend to be spread by either nursing staff, but in this instance was also likely spread by a resident who was roaming about and going into patient rooms. So these are this was the outbreak, and the relevance to antibody testing is the following. This resulted in an evaluation by the infection prevention team to look at the incidence of PCR positive and seropositive healthcare workers on the floor, to look at transmission in both ways, one from these patients to healthcare workers, but also to look at the possibility that a single healthcare worker might have been contributing to this outbreak. And in doing so, they collected serum. Now I'm going to just talk, and I'll talk about the results of that data in a minute. But that was the genesis of us doing serology testing on staff in the hospital. So just to give you a quick overview of basically the two types of tests that are commonly referred to in terms of antibody testing. This is what's known as a lateral flow test. In the bottom panel, you see, the COVID-19 coronavirus test itself. You can see the size of it. It's a small little plastic container that has a well on the right side. And that well is where you put the patient's blood. And then on top of that, you put a few drops of a reagent, a clear reagent. On the upper panel, and I'll use my pointer here, you can see that this is where that drop of blood would go. And these are the antibodies presumably in the patient's serum. And the flow is in this direction. So the serum is diluted by those drops of fluid. It flows into this panel here, where if there's an antibody against the SARS coronavirus, it binds to it. The SARS coronavirus is reflected by this green diamond. This is a gold bead that is attached to the SARS coronavirus protein. So the antibody sticks to this, and it keeps flowing, and it comes to an area on this nitrocellulose membrane where another antibody, which is directed against the human antibody, in this case IgM, will bind this, and the gold bead will stop right here. The serum continues to flow this way, and if it's an IgG antibody, shown here in brown, on this line, there is an antibody against human IgG, and it will bind it, and these gold beads will stop here. And this is a control line, which simply measures the presence of any antibody. And so you should have any antibody, whether it's to pneumococcus or group A strep or influenza, it will bind here. And so you get a readout with lines saying whether you have IgM antibody to the coronavirus or IgG. And that's what this shows down here. This is the control line, and this is an IgM line. The IgG was negative. So this is a lateral flow. It takes 15 minutes to do this test, and it is moderately accurate depending on which company you purchase the tests from. And this is what I think most people refer to when they talk about going to a drugstore and getting an antibody test, are these 15-minute tests. Some of them are awful, and some of them are reasonably accurate. All right. Here at RGH, in our research lab, and that's what I'm going to refer to, we do a much different kind of test. And this sort of shows on the left here how we do it. So each of these wells is depicted here. This is a well, this. We coat the antigen the same that green diamond I showed you a minute ago. We would take the same antigen and we would coat it on the bottom of this plate. We then wash out any residual antigen, and we then add the serum to this well, and we let it sit for an hour or so. And we then wash that out, and then we use an enzymatically labeled, this is alkaline phosphatase, and it's a mouse antibody against human IgG, just like in the lateral flow. We add that solution, and this will bind if there are antibodies binding to this antigen. We wash that out after an hour, and then we add a substrate for the alkaline phosphatase. And the alkaline phosphatase, if it's bound here via this antibody and the antibodies to the coronavirus up here, it turns yellow. And so this is a readout that we get in the research laboratory. And what this shows is that it gets lighter and lighter as you come down. These are three different patients here. So in triplicate here and in triplicate here. And what it shows is dilutions of the serum. So we make multiple dilutions of the serum starting at about 1 to 100 and 200, 400, 800, 1600, et cetera. And as you dilute out the serum, the wells turn negative. The patient here, you can see, has much darker color all the way down and has a higher titer. So in an assay like this, we can actually determine how high of an antibody titer the patient develops. All right, so these are the two basic kind of tests that you do. This is a research tool. It's not the kind you'll get in a drugstore, and it's not the kind you'll get in the clinical lab here. But this is what we do in the research setting. All right, so go back to those patients and what did we learn? Or these hospital employees. So in part of that outbreak, what we were studying is what was the incidence then of seropositivity to get a sense of the staff in terms of their exposure. So on 7,800, and that's what this represents here, about 23% of the staff were seropositive. This was approximately 33 individuals who we tested, and about 23% of them were seropositive. We then wanted to look at a control floor where there were no coronavirus patients. And in that instance, you can see here, this is again 29 patients or employees, and only one of them was seropositive, suggesting that the staff on 7,800 had a significant exposure with a rate of infection of about 23%. We then also, and now it's important to note that on 2,000 and 2,800, this is surgical floor, there were no coronavirus patients ever admitted there. This is the MICU and 4,800, which are coronavirus heavy floors. Essentially everybody up there was coronavirus at this time. And you can see, although it's slightly above this number where there were no coronaviruses, that the incidence of infection in the staff was actually quite low. Suggesting that what was going on here was a problem with wearing masks, gowns, and gloves, and being very careful, because 7,800 was a stroke unit, was not thought to have any coronavirus patients on it. And I think what we found is that the staff were perhaps a little lax. So that just gives you a sense of the antibody. I just want to point out that we've also collected blood on about 230 people who work in our emergency room. Unfortunately, our technician who does these assays in our lab, right around the time we collected it, developed a retinal detachment and was out for a month. And so we're quite a bit behind. I just want to jump now to the second topic, and that is a treatment trial for coronavirus that's going to be starting here at the RGH relatively soon. This is a background slide. The NIH has sponsored treatment trials for COVID-19. They're known as the Adaptive COVID Therapeutic Trials, ACTT or ACT. The first one, which was published in the New England Journal of Medicine, this was done at the University of Rochester, as well as at about another 50 or 60 sites across the country and even out of the country. And that was the one that was published in the New England Journal of Medicine. Ann Falsey was the PI over at the university for this, and it was remdesivir versus placebo, and that showed a 34% reduction in hospital stay and nearly a significant decrease in mortality. The p-value was 0.06, so it came very close to showing reduced mortality. So that was known as Act 1. Act 2, which has just recently completed about 3 weeks ago, also done over there and run by Ann and Angela Branch, who used to be a fellow who worked in our lab here for several years. That was remdesivir versus remdesivir plus baricitinib, which is a inhibitor of the JAK kinase system. And the idea here was to blunt the immune response to some extent, the inflammatory response. The results of this, and this has been completed with about 1,000 patients, again at the same sites, and the results of this are pending. So Act 3 is what's up next. But before I get to that, I'll just show you why we're going to be doing what we do. This is a preliminary information from a group in France. And what this shows here, this is mild, moderate, and severely ill patients with coronavirus infection. In all three, the color stays the same. Mild, moderate, and severe, and over here the same thing. And what this represents, ISG, immune stimulating genes, interferon alpha, and interferon activity. And what this shows is that in these severely ill patients, they have a rather profound lack of interferon. This is type 1 innate interferon activity in their blood, with the thought that the severely ill patients have a deficiency of it's type 1 interferon. Just over here, this is another paper which also looked at the same issue, and it simply illustrates sort of common respiratory viruses versus coronavirus, where common respiratory viruses, when they infect a cell, stimulate not only inflammatory chemokines and immune mediators, but they also induce very nicely interferons that are potent antiviral proteins that can protect cells. Whereas in the SARS coronavirus, there is a diminishment in this. This isn't actually unique to COVID-19. We've seen very similar results in infants with respiratory syncytial virus when we've looked at their gene expression of type 1 interferons. And I should point out that all viruses are very adept at interfering with the type 1 interferon production, some more than others, but this would suggest that these two papers would suggest that type 1 interferon deficiency, regardless of the cause of that deficiency, may be related to the severity of illness. And so Act 3 is going to be remdesivir versus remdesivir plus interferon 1 beta given subcutaneously. It's given 4 times every other day, so it's approximately 7-day span. The remdesivir is either 5 to 10 days, depending on the severity of illness. So this is the current plan. We were just activated as a site yesterday. We still haven't gotten the IRB approval though, so we won't be starting this right away. But this will be done both here and at the university as part of the NIH-sponsored treatment trials for coronavirus. And I'm going to stop there.
Great, thank you, Ed. So, while Chris is getting his slides up, just want to let you know that we now have 150 participants. So we've virtually tripled the number of people. You have a large audience. And I know you have a lot of material, so I'm going to let you get going, and we're going to save all the questions for the end.
Right. If you're ready for me to speak.
Yes, you're on, Raj.
Okay, great. Well, again, thank you guys for having me. My name is Raj Pyne. For those who I have not met yet, I'm one of the interventional radiologists. And to be honest with you, I don't even remember how Chris and I started getting into this a few years ago, but the main purpose of our talk today is we are really talking about and we're hopefully trying to implement now what we're trying to give it a catchy name, but we're calling it MAGIC, which is the Multidisciplinary Algorithm and Guidelines for Intravenous Access Consensus. So bottom line, the best way to describe how what Chris and I were doing is we're trying to create a general sense of guidelines for IV access for all of our patients, inpatient and out, really to create just a nice flowing pathway for which patient gets what, when, who does it, and things of that nature. Do you mind going next slide? So again, the basis for our talk was we started doing it because there was a lot of issues with placing power lines in our potential nephrostomy patients, but we realized very quickly that as we grew, growing out, taking a 10,000-foot picture, the big question was essentially every outpatient and every inpatient will need good IV access at some point to deliver the medications and treatments, obviously COVID patients and everybody else, for chemo patients, for renal patients. So what I'm going to do Lily to start is just to give you a little bit about the various types. I know a lot of people order them or talk about them or deal with them, but a lot of people don't know exactly what they are. So we'll talk about the various types, and we'll talk about which one might be best for each of your patients. So we will go with this is a picture from what's called the Michigan Appropriateness Guideline. And so I just want to give just a general overview, and the overview being, here are the different main types. So obviously everybody's familiar with peripheral IV catheters, whether they go in the hand or antecubital. obviously really the mainstay of treatment. One of the main issues we talked about is the question is how long can an IV stay in, and does every patient in the hospital need one? And those are questions that it's funny that you don't think about because it seems pretty automatic, but I don't know if we haven't had these older nursing guidelines, but part of it was at some point to really go through and try to make better definitive and delineate, more substantive guidelines on these. The thing I'm proud of is I think our nursing and our PICC team especially is start working on B, which is what's called the ultrasound guided peripheral IV catheter. And that's essentially the same thing, but it's using ultrasound expertise to actually get into the vein. It really helps for patients with difficult IV access. And it's nice because it'll allow you to get into different spots that might not be otherwise accessible just by pure sight or just by using the sight, the other IV's sight guides. Midline catheter, for those who don't know, is essentially the same thing as a PICC, but a catheter does not go generally defined as below the axillary vein. So pretty much it's a longer IV that stays in the arm or other area. Going to D, non-tunnel central venous catheter is what a lot of people know as the triple lumen or just through the neck as an IJ or subclavian catheter. That's usually, depending on where you are in the floor, that's depends on who places it, and it's good for access into a bigger vein. The E is a tunneled central venous catheter. That is essentially through what we place in IR and some other services places as well. It's a catheter that will go through the bigger vein, usually the IJ, but then will actually tunnel into the skin. And the reason is that actually prevents infection in the future, and it'll allow us to stay in for a lot longer. And the last final thing you may see, I'll go over G in the middle. That's the peripherally inserted central catheter, or PICC line, as we all know. And that's a catheter that goes in through an IV, which is essentially the start of an IV, but it's a very long catheter and goes all the way to the central venous system for other reasons, including central infusates. And the last thing I'll go down to F is a port. And a lot of the questions we get from people are, why would you need a port versus another catheter? And the general consensus we say is this is covered. So this is the only one of these catheters that's not exposed to the skin. So again, good for infection, the fact that it's not open, there's not a skin opening at the site. So it is used generally for intermittent access to intravenous for chemo or other reasons, or hydration and things like that over a long period of time. So again, if you're going to access continually, daily, multiple times a day, you're going to use one of the other ones. If you're going to use something, once or twice a week for, 6 months or a year, you're going to look for a port. So that's just a sort of general overview. Okay. And then the last thing I want to talk about just with, do you mind just going back, Chris, one slide? The main thing I want to understand, I want everybody to understand, and the reason that I'm very passionate about this is there's two sides to this. One is the short term. What access do I need for my patient? What will help me and help the patient get their medicine and get them in the short term, get them through the short term. The other issue for us and for me, and especially in the IR world and the vascular world, is the long term. The long term question is, what do not only these catheters, but what are the medicines that go through the catheters do to the veins? And that's also not just me, it's the nephrologists are very keen on this as well. And the reason I say this is because anything that goes through an arm vein, these arm veins are small, usually in the 1 millimeter, 2 millimeter range. An IV for a short period of time, a few days, you'll obviously notice if you have ever had an IV or get a blood draw or your patients, you'll get a little bruise there, maybe a little infiltrate, but for the most part, that'll heal. Once you get into a midline catheter or one of these bigger catheters, even a little bit bigger catheter, 6 French catheter like a PICC, then you're talking about a vein that maybe even going centrally that might potentially get scarred down or thrombus formation. Then the bigger catheters, the non-tunnel, the power lines, and even the hemodialysis catheters we put up to 16 French catheters in. Those are pretty big catheters, and that's why you want to put them obviously into the bigger veins. The reason we're talking about this is because long term, the longer you keep a catheter in, the bigger the catheter is, and the smaller the vein, the more you have risk of long-term thrombosis, scarring, and other issues with those veins. And that becomes a nightmare. We start dealing with that later on. And obviously you could in some really extreme cases, it can lead to really bad vasculopathy and even death. We had a young woman recently who had horrible venous access. So one of the main things we'll talk about, and you'll hear Chris talk about in just a minute, is how we are trying to go with the mantra going forward with this of you want to use the smallest catheter possible for the shortest time possible in the largest vein possible. And that's obviously it's with comfort and patient access in mind and convenience in mind, but we're going to go with sort of that mantra if all things are considered equal. Might go to the next slide, please. Thanks. So here I'm just going to talk a little bit about some of the catheters and what we're talking about here. So again, the PICC line, this is one of the most common things that are used after the peripheral IVs and the ultrasound guided peripheral IVs. But the main brand name, the reason I put the brand name here, just as what you might hear, because a lot of people hear it as a power PICC. And all that means is it's just a brand from Bard, and it's the one the hospital has. It's the only one we have here in the hospital, in IR at least. And what it means, the power designation means that you could do high flow injection through it. So CAT scan, MRI, some very rare, some infusions you might need, they go through, and this allows for that without rupturing the actual catheter material itself. But the indications for the most part are peripherally compatible infusions, so you could allow it to have peripheral compatible antibiotics, things like that. But if you need something centrally, you can give it as well, because that tip of that catheter is going to go all the way generally into the SVC or right near the right atrium. Frequent blood draws, long-term antibiotics, outpatient, TPN can definitely be given through this, even chemotherapy. And for some rare patients who might do hemodynamic monitoring, things like milrinone, other cardiac medications you can give through there. For the most part, 2 weeks to 6 months. Again, we'll talk about the fact that we want to minimize how long that's needed, how long that's indwelling if not needed. And the contraindications we'll talk about are sometimes our ipsilateral DVT. This is a big issue. We always talk about the fact that if you have some swelling in an arm, the next step for a lot of people is to get an ultrasound. And one of the ultrasound, what you'll see that the report a lot of times will say PICC line with maybe something else there, maybe a small clot. For the most part, it's very hard to tell. Once you get a PICC line in somebody, if you haven't seen it before, the body develops a small fibrin sheath around any foreign body, especially in a vein. So a port, I'll tell you this, when I take out a port, we make the cut down and go down to the port itself, there's a small membrane. It's almost like a little cellophane or saran wrap around the port itself. You make a cut, and when the port comes out, it looks brand new. So it's the body's way of, just a reaction to protect the body from this foreign body. So same thing here. A lot of times it's hard to tell, is it actually a clot? Is it the fibrin sheath around this PICC line? What is it that we're doing when we actually get an ultrasound? And a lot of times people would argue that it's there in 100% of cases. So we have to be careful there for that ipsilateral DVT, if it's there and caused by a PICC line, or if it's actually just the fibrin sheath. For other contraindications we talk about are the CKD in those patients. And for those who aren't aware, what it means is that in the future, we're trying to preserve access for those veins for fistulas, because we want to always have fistula first. It's a better access for the patient, it's more natural, and it's less likely to get infected. So to allow that, we don't want to have PICC line, because long-term PICC lines can scar those veins down and prevent future fistula creation. And last thing, sometimes we'll talk about is contraindications and active infection or bacteremia. For the most part, some of these patients, even though you don't want that, this is the only option for them if they can't have an IV, so that's actually a relative contraindication. For a PICC line itself, just for understanding the basics of it, it's placed usually be an arm vein. We usually use the basilic, the brachial, or the cephalic. A lot of times, for the most of them, I think by far the most of them are placed by the PICC team, and we have a wonderful nursing PICC team who will place them on the floors. They're very adept at doing this. If not, some of the times we're placed by IR if there's an issue, or sometimes if there's mastectomies or the access is very difficult, we can place them in IR as well. Power PICC, again, just so you understand, it's a type of PICC. It can be power injected. There are different PICC lines. For the most part, we put in dual lumen PICCs. They are power PICCs, so it's just more of the default of this 6 French dual lumen power PICC. But there are single lumen and triple lumen PICCs. Realize that it sounds good to have a triple lumen, but if you're going to have a 6 French with 3 lumens, you're obviously getting much smaller lumen per, much smaller caliber per lumen. So understand that if you need more flow for some reason, you might want a dual lumen, and we've talked about getting the single lumen PICCs in here as well. Not just for more flow, but you actually go down to a smaller 5 or 4 French size, better for the patient, going with that mantra of smaller lumen. Long-term PICCs, again, I want you people to understand this, they can thrombose and scar the arms and central veins. They're great for short-term, they're great for patients, healthy patients, but smaller veins, longer-term, just be careful that it could be an issue with scarring those veins. And again, feel free to consult IR anytime if there's a failed PICC line or a more challenging PICC line. Next slide, please. This is what it looks like. If you look at a PICC line, you'll see them in the arm. We'll generally not suture them in. I don't believe the PICC team sutures them in either. You'll see this little dressing there, and both of them are easy to use. A lot of times you'll see that red port is a little more open, and the purple port sometimes a little bit smaller, but both of them are easy to use for anything you need. If you're looking at that picture on the right, it continually to me looks like needleless connector, but it's needleless connector. So we do that so you don't have to have any needles in there, and there's a disinfection cap, so they're pretty easy to hook up and use. Next slide, please. And this is what you're looking for on the x-ray. So you're seeing that there's the tip of that catheter. We're generally looking at that. Could you go next, Chris? So you're going to see that's the SVC on an x-ray. And then the next one, if you can put it in there, I'm going to show the right atrium. Thanks. So that's the right atrium. Then you're going to see that you pretty much want that PICC line right to be at the cavo-atrial junction, which is at the distal SVC going right into the right atrium. So that's what it looks like. And then just a long picture to understand how long they are. When you're taking them out, they slide out pretty easily. There's no cuff or anything there. They'll slide out pretty easily, especially if they're infected, but they're very long catheters, all the way up to 55 centimeters for some of these arm veins. But that is what a PICC line looks like. Next, please. Midline. To understand what a midline is, for the most part, essentially when we place it, and we rarely place these, it is just a PICC line that either is purposely placed shorter or is just cannot get past an occlusion or something else. And I placed one the other day. So it's essentially the same exact brand. It'll look the same from the outside, but on the inside, it's just a catheter that doesn't get generally past the axillary vein. So same thing, you'd use it for IV fluid medications, peripherally compatible infusions. The only thing you can't use it for is something that you need centrally infusated. So again, a little shorter term. The argument here for some people that I've heard is, you won't get a, central line eclampsia. You're not talking about central line infections with these, which again, I think is sort of skirting around the purpose of why people track these things. So a midline is good for what it's, good and what it's needed for. And that is IV access for a little longer term than a normal IV, but just one that you can't get generally centrally. And again, for the considerations on the side, place to be an arm vein, can be put in at the bedside by the PICC team, can't be used for central infusions. It's less likely to scar the central veins because it doesn't go that far, but in most cases it already has a blockage or some issue there, so that might be a moot point. There's a long-term, it can thrombose the arm vein, so it's not like a midline is any better to prevent for future fistula formation, so just understand that. Not recommended for TPN, corrosives, or again, irritants because they won't want to go centrally. And then obviously there's a pH issue as well for infusing through them. Next slide, please. And again, just a quick understanding of the PICC line going all the way centrally versus that midline. A lot of times will stop. It'll look the same from the outside. Next slide, please, Chris. Thank you. Non-tunnel central venous line. So again, a lot of the prominent companies that we use here in the hospital are Cook and Arrow. You'll see they'll come in a whole kit. For a lot of people who place them themselves, a lot of people, one of the issues we've talked about with Chris is a lot of times in some areas, the hospitals may not do this very much anymore, and you might not be comfortable with that. So, you place these probably for critical patients or somebody who just has poor peripheral issues, somebody who needs central infusions or frequent blood draws. This is also used much more commonly for hemodynamic monitoring, and again, especially for TPN for malnourished patients. You could keep these on for 10 days. Again, that's more of a general guideline, and I believe it is also the hospital guideline, but that is up for debate. Some people will say less than that, 5 to 7 days. Some people argue that you can keep them in longer. A lot of it is hearsay. There's not great literature to go one way or the other. Contraindication for this generally is, relative one is a coagulopathy, but for the most part, we can place a non-central line in patients even with high INRs or who are on other blood thinners. And because you're doing a direct access, especially in the IJ, which is the most safest, is the safest, it should be fine. So again, considerations generally for emergency access. A lot of times triple lumen is the default, but understand also there are single lumen and dual lumen catheters available. And again, in the IR world, I know it's not true for all fields, but we strongly recommend internal jugular for safety and for size. Preferred over subclavian, just because of the risk of pneumothorax, and placed over femoral because again, it's a dirtier site, dirtier meaning more chance of infection. And for patients, they don't like that. It's just not comfortable for them either. Next slide, please. Here's just a quick picture of a central line. What you're looking for is that coming generally from the IJ straight down, no kinks or curves there, with the tip going right at the cavo-atrial junction, which you are now very familiar with from the other slides. And again, this is the graphic showing the picture through a subclavian vein, which we don't recommend, but again, it'll look exactly the same thing. Only difference is it'll come under essentially for the most part under the clavicle there. Next slide, please. Tunnel central venous line. Now we're getting into what IR generally does. The reason being is this is a procedure that will need conscious sedation and a little more tunneling through the skin. So it's definitely more challenging than more bedside catheter. So this is we generally talk about for the most part. If you hear the words power line and Hickman, a lot of confusion comes with the power line. Power line is something that we have not really placed until about 3-4 years ago, and it's become very, very popular. And I think there's a lot of confusion surrounding it, so we'll talk about that. But for the most part, same things as a non-tunnel line, same reasons you can be using it. And again, you could put it in, especially when you PICC line is contraindicated. Possible CK4 or above patient or a patient who has very poor IV access. These can stay in a lot longer. Because they're tunnel line, they're protected better from infection. So we have our tunnel lines in for patients, especially for Hickman's or power lines, cardiac patients and our oncology patients, they'll stay in for weeks to even months. Contraindications are again the same, but we're adding in things like coagulopathy. So if their INR is higher than 1.8 generally, or platelets lower than 50, we got to be careful. For the oncology patients who have very low numbers, thrombocytopenia, we will work with trying to optimize those numbers. But for the most part, we can get these in. The smaller the lumen, obviously the less the bleeding risk is. But the main thing I want people to understand is the power line. A lot of confusion happens because people think a power line is very similar to a PICC line. A power line is not a PICC line. It looks similar, but it's going through the IJ and it's put in just like any other tunnel catheter. So in IR, under conscious sedation, they have to be NPO for 6 hours. And I'll show a picture of that in just a minute, but it is a great line. It's power injectable. You can give things centrally. So it's pretty much used for a lot of things, but it's a very small line. It's much more comfortable for the patient because it's only a 7 French catheter. Hickman's are pretty much the same thing. Just think about them as in growing in size. Hickman's, we have a 9 and 12, but the power Hickman we have is a 9 French. Used for chemo and bone marrow transplant. The Hickman itself, the regular one we use is a 12 French. That's a bigger line. It's not power injectable, but mainly used for chemotherapy and bone marrow transplant when you need, obviously, bigger lumen, bigger flow, so we can get more flow through it. In some patients who need apheresis, we'll actually go for the largest bore catheter. That's the same one we use for dialysis, which is a 14.5 French up to a 16 French catheter. It's a very big catheter, so you can actually get full volume turnover within a few hours. All right, and again, I talked about that power line is a more invasive line. Just please understand it's not a PICC line. Next paragraph. Sorry, my radiologist dictation just came in there. Sorry. Next slide. This is the power line again, just to see what it looks like. Smaller catheter, looks exactly like a PICC, 6 or 7 French, but patients find this a lot more comfortable because it's a lot smaller and it's a lot less intrusive. And then Chris has a nice picture of what it looks, what a tunnel catheter looks like through the skin there as well. Next slide, please. Implanted ports. Quickly, we have a lot of different brands for this. But again, we're using Bard, we're using Dignity, Metaport, you'll hear Portacath. These are some of the older ones that use. I just want people to know they're all the same thing. A chest port is just a implanted port placed in, for the most part, in the chest. We place them in the thigh or in the arm sometimes for some patients who have other issues. And I should go back and just say for PICC lines and other lines, we will put IVs or in anything. I put them in breast and the abdomen. I put them in legs in very odd spots for patients that need it, just because there are patients who get really vasculopathic here. So indications, again, this is the main thing for a port is infrequent access on a long-term basis. So generally chemotherapy, hydration, things like that. Patients love having this because a lot of these patients, same chemo patients, will have very poor IV access. So I remember my grandmother when she had a cancer, the worst part she told me was that getting her IVs done every day, every week at Sloan Kettering was the worst part. So I'm not sure why she didn't have, years ago she didn't have a port placed, but I think a port or IV might have been something that would have spared her a lot of pain there. So again, a lot of, I think most people know the indications, durations. We've had these in for 5-6 years. So these last for a long time. Patients become very attached to their ports. And then again, same thing for the contraindications. When we place them in IR, they're able to be used immediately because we test them. If you need them or I need chemotherapy induction the same day, we'll keep them accessed. Otherwise, we will put heparin and then de-access them, and they can be accessed the same day, the next day. One of the things to know with a port, if you are able to flush it, and everybody who uses the port knows this, but for anybody else who doesn't know it, if the port is able to flush, but you cannot draw blood back, then you really got to think about a fibrin sheath around the tip of the port. And the way to think about that for a fibrin sheath is it's almost like a sock around a foot. So when you push in an injection, the fluid goes through the lumen, goes around that sock, and then comes out. When you try to pull back, that sock gets sucked into the lumen, and then you don't get it. So it's a very typical sort of history you'll hear for that. And either you can put in TPA, or we could actually strip that fibrin sheath out. And again, if you need power injectable, let us know. There are power injectable ports. There are MR compatible ports. If you have somebody who really needs has a pacemaker or needs MRI, or sorry, who doesn't have a pacemaker, who needs MRIs, we can put that as well. Next slide, please. These are what they look like. On the right is a single lumen port. Those little bumps are what helps people get access into them. On the left is a dual lumen port. Next slide, please. And again, this is how you access them. Understand that for the ones that we're placing that are, especially the barred ones, which are very common here, that we place mostly, that bottom left shows that if you look at that triangle, the word CT are there. So if they want to inject them for a CT, those words on the X-ray will show up. If it's flipped, it will be a mirror image. So next slide. That's what a port looks like, obviously, on the skin. So that's easily accessible here. You'll see those 3 dots coming through the skin for the most part to make it palpable. And if you look on the right, there's a port that looks normal. But if you look at the enlarged picture, you'll see the CT's flipped. That port is flipped. You will not be able to access that. So just quick, if you're looking at your patient, you think there's an issue and it's inaccessible, that's what we're looking at for the CT markers there. Next slide, please. Here's one. If you look at the top, you see where the IJ is at that patient. That is a kinked port, and that's what somebody might get a lot of pain and issues if they're getting chemotherapy. And because that's kinked, you see that tip of that catheter is pulled all the way back up into the mid SVC. Again, what we're looking at when we're looking at these X-rays. Next slide, please. Last thing I'll talk about just very quickly are the non-tunneled hemodialysis and dialysis catheters. Again, we could place these. They're much bigger catheters, so again, up to 14.5 French typically. This is something that nephrology will call us to place all the time. Sometimes they're placed by ED. Often they're placed in the ICUs, but realize that if there's any issues with that, you can call IR at any time. And then the tunnel dialysis catheter is essentially only placed by us, although I think vascular surgery will place some of them as well. Next slide for that.
I just wanted to, one thing I just wanted to add that I think it was Dr. Riggs shared with us is that if we're putting a short-term non-tunnel dialysis catheter in the IJ, and the plan is to change it over a wire for a tunneled catheter, that we ought to aim lower in the IJ. I think many of us who place central lines generally try and hit higher up in the IJ to avoid pneumothorax. But if the plan is in the morning that we're going to switch this over to a tunneled catheter, to aim lower in the IJ to allow them to use the same path.
So that's a great point. That's one of the biggest issues. If you notice, a lot of times we'll actually put a new catheter next to a previously placed non-tunneled catheter. If you go back one slide, if you can see, that's why. If you see this one, the axis was really high above the clavicle. So what happens when you do that is when you come from the side, the higher you are, the more you get that peak. What we want is a big giant slope, because we want a catheter to take a general, sloping gradual course. The higher you go, the more likely you are to get a kink like that, and that's what kinks off the catheter. So we will go very, very low. If you can go lower, obviously that will be better placement for us. If not, then we'll probably go adjacent to it. All right, do you mind going forward a few slides? This is what a tunnel dialysis catheter looks like. Just realize the one difference between this one, because we need higher flow, we need to be in the right atrium. We will place the dialysis catheters with a tip in the right atrium, not in the SVC. Okay, next one. And this is what the catheter looks like. You see how deep that catheter is. That's on purpose for flow. All right, next. There's the tip of that catheter in the right atrium. All right, so that's why with all this, it's very complicated, and we're trying to make these guidelines, for the major question of which patient should get which type of venous line and when. And the one other big question we always have in the hospital is who will place it.
Right. So very much thanks to Raj for all the introduction about the various different types of catheters that are available, and also for the spectacular acronym that he's pulled together. So that was great work. So as Raj made mention of earlier, the fistula rates for dialysis patients in our institution are somewhat lower than we would like them to be. And the real problem is that if we're not using a fistula, then we're using a tunneled central line, and the tunneled central lines are higher risk for infection. And the suspicions a couple of years ago was that our high rates of PICC utilization were leading to central venous stenosis and preventing the development of functional fistulas, and also preventing the surgical creation of fistulas because the arm veins were sclerosed or thrombosed. However, there was this ongoing tension between maybe an acute care hospitalist who was really trying to get medicine into the patient, this week, and the longer term prognosis of the patient who might be headed for dialysis in the next year or two. And trying to figure out, trying not to put the PICC team in the middle between a nephrologist who would say, can't put a PICC line in, and a hospital that said, well, I can't get a peripheral line in. And I think that led to the explosion in the requests for power lines that Raj alluded to earlier. And perhaps the misconception that a power line was a quick and easy thing like a PICC line did not consider the point that the risk of anesthesia is a real thing. And that these power lines are not designed for a 3 or 4 day hospitalization. They're instead designed for weeks or months of therapy. We reviewed the Michigan appropriateness guidelines for IV catheters. And we pulled together a pretty large group of initial participants to start thinking about this problem. I think it was about 2 years ago now. We did a literature review. I did a little bit more literature review. We looked at institutional policies. And then over the course of a year and a half or so, Raj and I went through a variety of different constituencies to try and solicit input so that we could build an algorithm that would hopefully work across the institution. We're looking only at RGH right now, but if this works well here, we'll probably think about how to do this at other campuses, though certainly other campuses have different needs and different capabilities. So this is the algorithm that we have developed. I suspect that over the coming months or years, this will be tinkered with some, but this is a very thorough algorithm for a variety of different situations. And probably the only thing you can read here is that the philosophy is the smallest bore catheter needed in the largest vein possible for the shortest time period. We'll zoom in on the different parts of the algorithm now. So for an unstable or critically ill patient, a large bore peripheral IV, emergency non-tunneled central venous line or intraosseous line would be appropriate, and consider a temporary dialysis catheter with a side port if dialysis appears to be imminent. If you have a stable patient but has renal disease, we need to find out whether we're talking about dialysis access or not dialysis access. And in our conversations with the nephrologist, the way that we're defining whether the patient has renal disease is any patient with acute renal failure on CKD, or a patient with CKD 4 and 5, or a dialysis patient, or someone who's a potential transplant patient who also has a life expectancy of greater than a year. So if we're looking at dialysis access, we're either looking for temporary non-tunneled catheters or a more permanent tunnel dialysis catheter. And if we're looking for non-dialysis access, then we're hoping to get a peripheral IV in the dorsum of the hand or ultrasound-guided single IV. But if that's not possible, you see we have a column here for the technical failure plan, and that is that we probably need to, as an institution, get better at single or triple lumen central venous catheter placement. The next section of the algorithm was developed in consultation with the oncology team. So depending on what the patient's disease state is or what the therapy that's needed, there are a variety of different access plans. And we also need to think about whether this is the first hospital stay for an acute leukemic or whether this is a longer term after discharge plan. And the one thing that will be very helpful to the proceduralists who place these lines is to make sure that we're clear about what kind of placement we need, what kind of catheter we need, a single or dual lumen catheter. And in general, the ports should be placed for outpatients, not generally in the hospital. And then there is a theoretical risk that TPN administered through a port could increase the risk of infection. The nutritional value of the TPN may dwell in the reservoir of the port and be a nidus of infection. All other patients fall into the biggest section of this algorithm. And then there, the breakdown really falls between whether we're talking about a peripherally compatible infusate or whether we need something that would be infused centrally. Then the next question is, well, how long do we need access for? And there are a variety of different options depending on the length of time that's needed. And if you're unable to get whatever we think is the primary access type, there's a technical failure plan. Most of the time it involves consulting interventional radiology. Thank you very much to Raj and his colleagues. But there are a few hospitalists and some APPs within the hospitalist group who have developed expertise in the placement of ultrasound-guided IVs. The IV service team has also developed expertise in this, and I am expecting that over the coming years, many more of us will develop this expertise. And again, if we're unable to get midline catheters, then a single lumen central venous line, or if the patient's going home, a PICC line would be appropriate. But again, we'll need to get better as an institution at how to place these central venous catheters. And that comes to the next and potentially an area of debate within different departments. But the question is, whose responsibility will it be to place these catheters? And again, I think this is something that will likely be adjusted over time as we try and match the demand for different lines with the capabilities and workforce of the various different services that may be called upon to provide these services. Certainly peripheral lines are done by bedside nursing and IV service. And if that can't be done, then the attending needs to be notified and we need to follow the pathway for the technical failure plan. Ultrasound guided IV placement has now been done by IV service. And as I said, there are a few attending hospitalists who can do this and the folks in the ED, and sometimes ENIT can do this as well. I think the main area of potential change here is in the emergent or urgent central venous catheter placement. If the attending physician is capable of doing this, we expect somebody who's credentialed to do this to make an attempt at placing such a line. But depending on which primary service the patient is on, the teams within the critical care units have all been willing to participate in assisting us in getting central venous catheters. This is medical grand round, so I want to give a special call out to Daman Palsandi and Todd Shepard, who have said that the ICU team will help the medical services with the placement of urgent and emergent central venous catheters when necessary. If that's not possible, the surgical hospitalist can help. If the patient's in the ED provider can help, and as a sort of backup of last resort, interventional radiology may be a source of someone who can help us place urgent central venous catheters. Midlines and PICC lines are done by the PICC team, and if necessary, by the MICU APPs. There are a couple of them who are able to do that, and interventional radiology is the backup there. IR does all of the power lines. IO lines are done by ENIT and ED providers. Non-tunnel dialysis catheters are essentially the same thing as a triple lumen catheter. And so folks who are credentialed to do one are credentialed to do the other. It's not something that many hospitalists have done in a long, long time, and so that may not be an appropriate proceduralist. The surgical hospitalists, the ICUs, and IR are also available to help us with this. Tunnel dialysis catheters and Metaports are done by IR and surgery. The ED has placed some external jugular catheters. It's not something that we as an institution have a lot of experience with. There are some nursing policies that prevent their use on the floors, and that's probably going to be an area for further discussion over the coming months and years. So where would you find this protocol? Because it's probably the case that not everybody has completely memorized it with the one slide that we showed. And so I want to give everybody's attention to FormFast. If FormFast is not one of the tabs that you have on Care Connect, you can wrench it in. There's a little wrench space over on the right. And you can click on FormFast. And that will pull up a variety of different documents. And if you use the search function for IV access, you'll see that we have both the algorithm and the responsibility hierarchy. And the way to actually look at them is to double click on the icon at the far right where there's the paper with the spyglass on it. That will give you a PDF of the documents that I've showed in these slides, and you'll be able to follow the algorithm to what you need. So we are expecting that we will end up developing a Care Connect order set for IV access, which will provide decision support and guide you through what you need. There was a very clever idea of the 922 line idea. This has not been instituted yet, but it's a clever idea where you could call 922 line and it would take you through a phone tree that would help you decide what type of line you need and then connect you to the service who could provide it. We probably will not put this on SharePoint or the portal, but that may be an opportunity at some point in the future if the FormFast access is not adequate. As I mentioned earlier, there may be mismatches between supply and demand in terms of workforce and how many lines need to get placed. And so that'll lead to further interdepartmental discussions if we find that this protocol is not working for one group or another. There will certainly be new products that come along in the coming years. We'll have to figure out how they fit into the algorithm. We'll want more folks to be able to do ultrasound guided lines. There was a suggestion that maybe we need a protocol arm for IV drug users. We'll need to figure out how we would define that and whether the current protocol really does not work for that population. Not yet clear what the role for the anesthesia service is, but that's something that maybe we can add to this in the coming months and years. And then I think another next step will be making sure that we remove catheters as soon as possible. I think one of the most important messages about central venous catheters is that we should take them out as soon as they are no longer needed. And then just a quick plug for the IVC filter removal guidelines that are also on the protocol. These can be taken out indefinitely, so even if the patient's had one for a longer than necessary period of time, please do still call the IR folks and have them take it out. And that's what we've got.
And the only thing I want to add, Chris, and I think you and I have talked about this, just for everybody to know, this is a living dynamic document. So as we're going through time, we're meeting with everybody, and every time we meet with somebody, we'll meet with somebody else who might have some suggestions. So if there are suggestions, please reach out to us. We'll be happy to make those changes and implement them if it's a service that you run, or if you have something else that you would add to it or help with that. Please understand that we're doing it for 2 years, so we're trying to get it out to implement it, but it's always constantly evolving. So please feel free to reach out to us.
Great, thank you. We do have a few questions, and I think we have a couple minutes to answer them. So Dr. Sham raises the question of catheter-related thrombosis, and a couple of different issues related to that. One is, can we develop a uniform way to report sheath versus real thrombus? And then how do you manage catheter-related thrombus? Does a catheter always need to come out? How long do you need to anticoagulate someone? Comments on that, Dr. Pyne?
I think it's a great point. I think it's age-old question. Hard to tell between what is a fibrin sheath and what is a clot. Sometimes if you could tell if it's an occlusive clot, then yes, I think it needs to come out immediately. Some others will argue that once it's already clotted, that vein's probably going to have issues. Leave that access in as opposed to getting a new vein. So I agree. I think we should do guidelines. I don't know. It's going to be very hard because every patient is so different. So I think we have to sit down with the hematology service and really hash out something. But I agree that that's probably long overdue.
Yeah. So usually, if it's an occlusive thrombus, we will recommend taking the catheter out. And then once the catheter is out, you probably don't need prolonged anticoagulation. We usually say 6 weeks is enough. Right. In general, that's the hematology approach, but I mean, you could probably have a whole other grand rounds on management of thrombosis in these patients. So Dr. Hussein asks, does tunneled central line not cause local scarring like a PICC line? I'm not sure what he's asking actually. Is it the chest scar? Is that what we're talking about?
We're asking about central venous stenosis.
I think that's probably about central venous stenosis. And the answer is yes, over long periods of time, yes. So the patients we see that have central venous stenosis and SVC's, syndrome, things like that, the most common cause is long-term central venous catheters. The other one is pacemakers. So as soon as you have a wire or catheter in there, if you get away with it for a few weeks or even a couple of months, they should be okay. The patients who have had the pacemakers or the catheters for 3, 4, 5 years, that's one of the major reasons that we don't want a catheter in place besides the infection is that central scarring. So yes, long-term large bore access or pacemaker wire access or presence in the central veins will cause them to scar down over time. Yes.
Okay. So Natalia, pediatric hospitalist, asks, what is the lower age or size limit of a patient we can refer for PICC placement?
That's a great question. I've put them in children before. Issue with us is with anesthesia, it's credentialing for sedation for children. So children can't come in. If it's obviously it's a teenager, we have no problem doing that as long as the anesthesia is there. I have put it in younger children before. The problem is we don't have sometimes PICC lines that are that small. So we have done those in the OR. If it's an emergency basis, you can always call us as long as the anesthesia is comfortable. We'll get the smallest bore catheter and do it. Otherwise, if it is a smaller patient, it's not elective. We don't have the credentialing sedation-wise to do that without anesthesia, and we don't have very, very small catheters stocked. So those are the two main issues.
Yeah, so follow-up to that would be we sometimes have a hemophilic patient who needs a port, and you guys are not doing that at this point. We're sending them to the pediatric surgeons at the U of R.
I think it's best.
Yeah. Kelly Madmati asks, or it's more of a comment than a question, in neurocritical care, subclavian central lines are preferred over IJ to prevent cerebral venous congestion in patients with increased intracranial pressure. So just a point that we should keep in mind, and thank you, Kelly, for that. Ed, are you still around? I think he's gone.
Yes, I am.
Oh, he is. Okay. So there was a question about the outbreak on 7800, and how many of those staff members got sick, and how sick did they get? Do you know the answer?
Of the PCR positive individuals, initially, I believe 2 were symptomatic mildly.
Yeah.
Of the majority who were asymptomatic at the time they were tested, roughly 1/3 became symptomatic over the next week or so. And so in total, about half remained asymptomatic.
Yeah.
I should point out, interestingly, when we looked at seroconversion of those PCR positive individuals, of the 10 that were PCR positive, this is the staff, only 7 of the 10, 2 weeks following the positive PCR, 2 to 3 weeks after the positive PCR, only 7 of the 10 had developed antibody. And the 3 that did not were asymptomatic or very mildly infected. And this is actually a theme that is appearing in the literature, that asymptomatic individuals and people with minimally symptomatic disease may not be seroconverting or developing the amount of antibody that symptomatic individuals and severely symptomatic individuals develop. So we have data on hospitalized patients who've been here for 3 to 4 to 5 weeks, and their antibody levels are significantly higher to the spike protein than what we were seeing in our healthcare workers in general. That may not be that surprising.
So if you screen people with serology, then do you think you're missing some people who?
Sure. Yeah, it would strongly suggest that you're going to be missing mild illness that hadn't occurred. On the other hand, if you are simply looking for a positive versus a negative antibody test, I think you'll pick up more. We would quantitative as opposed to just a qualitative. We also didn't do IgM. We have not done that. The lateral flow tests do measure for IgM, but I have to say IgM assays are notoriously fickle and can sometimes give you false positive readings. In fact, they're much more likely to be erroneous than an IgG assay.
Well, thank you. We're pretty much out of time. Our next grand rounds will be in 2 weeks. And the theme will be respiratory failure in COVID patients. So there'll be a couple of cases, and we'll have pulmonary docs and others presenting on that. So look forward to that in 2 weeks. And then after Labor Day, we go back to our typical weekly grand round schedule. So thank you all for attending, and I'm going to stop the meeting there.